Hello and welcome to another episode of Health Show with Amara from our London studios. Health is every human being's priority, and where there are so many conditions and illnesses affecting human beings, there is one condition that affects millions of girls and women all over the world, a condition called polycystic ovarian disease or syndrome. This condition may be overlooked and misunderstood, and when a diagnosis of polycystic ovaries or a polycystic ovarian disease or syndrome is made, it has got a major impact on women's mental health as well, because it is taken as a sign of infertility. Women think they can't have children and their life will be a mess. As I said, it is a condition which is misunderstood. So in order to talk about the background and the management and treatment of this condition, we have invited today an expert in this particular field, Dr. Gul Bano. Dr. Gul Bano is a reader in endocrinology and diabetes in London. Not only that, she has got research interest in polycystic ovarian disease as well as genetic background of a lot of endocrinological problems. Let's welcome Dr. Gul Bano.
Thank you, Amara. Thank you very much for giving me an opportunity to talk about this complex endocrine disorder called polycystic ovarian disease or syndrome. It is one of the most common hormonal and endocrine issue which as an endocrinologist we see. And it's very interesting. We start seeing them very young because I also do young adolescent endocrinology. So I start seeing them at the age of 14 and 15 when they're presenting mainly with menstrual problems. Then I see them in adult endocrine clinic when they have other manifestations of this. See them in later in diabetic clinics because they have very high chances of becoming diabetes. So you can see is a whole spectrum of disease starting from one to the other end. Like you rightly said, there are huge physical and mental complications, aspects of this disease. And unless somebody is a patient listener and you can't address each and every issue. So it is a truly a multidisciplinary specialty. You require a gynecologist, you require endocrinologist, you require physicians sometimes and dermatologists. So I'm just going to talk about what is this polycystic ovarian disease. Now, it is characterized basically a combination of signs and symptoms, and which are mainly due to male hormone excess, which we call as an androgen excess. And this results in ovarian dysfunction. And then clinical manifestations are irregular periods or complete stoppage of periods, infertility or subfertility, in excessive facial or body hair growth, and acne. This disease was actually first described in 1935 by Stein and Leventhal. But over the time, interest has increased in its research, in its pathogenesis, and we know a lot more about it, why it happens, what can we do it. And if I was asked one thing which would modify the disease, it would be keeping your near normal body weight.
So, Dr. Bano, could you just tell us, is it a genetic disease or it can be acquired?
Extremely good question. We know the genetics have, some of the cases have been well worked out because it runs in families, but we don't know what kind of inheritance it is. It looks like it may be autosomal dominant. 50% of the children might be affected. The counterpart of polycystic ovarian syndrome or polycystic ovarian disease in males is early male baldness or male pattern weight loss of hair in men. And the things which give you an acquired form, maybe it was from the hormonal point of view, it was quite a disease, but if anybody gains weight, that means you are putting your insulin at a very high level. This complex is the problem and manifestation happens early. So it is just like type 2 diabetes. You have got an inherited problem, but you need a right environment to manifest. So I would say, yes, it is partly genetic. and partly environmental. So, why I'm saying this? Because when we looked at the prevalence of disease, it is different in different ethnic populations. In Western Europe and in native and Western Europe and white Caucasian population, prevalence is about 6.5 to 8%. And when we come to Asian population, the one which I studied mainly because of my local demographics, is about 20%. But that does not mean to say that all 20% of them will suffer from the problems. Problems can be controlled in these cases, like I said. So when we talk about polycystic ovarian disease, is a spectrum. On one hand, you have got lean, thin girls with just polycystic ovaries and ultrasound scan, but they have regular periods. They haven't got excessive facial hair. Then in the middle, we have got slightly overweight women who have got slightly more excessive facial hair, irregular periods, but not complete amenorrhea stoppage of period, and maybe some problem with fertility, but can be treated easily by weight loss. And on the extreme end of other spectrum, we have women who are very much overweight or high BMI. They have got proper hirsutism, that means excessive facial hair, and they are amenorrheic. And you can see from this presentation, this is the population. Luckily, small numbers, but they are going to present with problems regarding their appearance, regarding their mental health, and regarding their fertility. So how do we manifest, what do we call it? So that's why I call it a hormonal, ovarian, and metabolic disease. So that's what we are looking at, the long-term effects of this disease.
Okay. So,
So
Dr. Bano, you just mentioned that there are different types and
yeah,
they manifested in different ways. So,
yeah.
when you see these women in your clinic, most commonly, what is the commonest problem they present with? Because my experience is that sometimes a young girl with any period related problems, they have a scan and scan has shown multiple cysts, and the mothers get worried because they just think that their daughter is not going to have children, so that
Yes.
makes them worried and they bring them to clinics for further discussion. So what is your experience on
Yeah.
patients coming to your clinics?
Yeah, I exactly agree with you. Like I said, if I'm seeing them in an adolescent clinic periods and a scan which picked up polycystic ovaries. So I always tell these girls, as long as you have more than 6 periods a year, you have an equal chance of conceiving like anybody. Please do not put on weight. And I reassure mothers, because it's not going to cause problem. It's quite a common condition. Whereas when I see in my adult endocrinology is mainly the fertility issues where they come in. Hirsutism or excessive facial hair growth, appearance problem, and also the fertility. And I think you see them in your clinic mainly from subfertility and fertility. So that's why it's like it depends on which clinic you are sitting. But I can see the anxiety more in mothers than in the person himself about not having family in future. And as you know, Google is a very good media. They go on, they Google this polycystic ovaries and come up, oh, they are never going to have children. A lot of time I'm asked the question, should I be having my eggs preserved or should I be going for IVF? And we will talk about it. I think you are much more familiar with that side of things, that a lot of them will go on to conceive spontaneously, although there may be problems during pregnancy. So, like I said, what when we diagnose somebody with polycystic ovarian disease, if they have normal body weight, they have no other metabolic complication, there is no need to panic. And then comes the second stage when they have excessive hair growth, slightly high androgens. We need to address them. And then everybody is different. You have to ask them, what are they looking for? Are they looking for regularization of period? Are they looking treatment for their hair growth? Are they looking for fertility? Now, depending on that, so you have to get your diagnosis absolutely right. And the diagnosis involves a very good history to see what is happening with the periods, an examination. And I always tell, when you're talking about hair growth, please have some way of measuring that hair growth, because a lot of people will say, I'm hirsute. But when these girls are comparing themselves to white Caucasian girls, they are definitely hirsute, but maybe not from the Asian standard. So we use a tool called Ferramin Galway score, where there are 9 areas we look for the hair growth. And in Caucasians, anything above 8 is scored as hirsutism, whereas in Asians it is 12 or above. So you can see the difference is we are generally, ethnic population is more hairy as
So you
compared to the
think that
local
do you
population.
find it easy to explain this to
Yeah,
Asian
yeah,
girls or women, the differences? Because clearly Asians are generally very hairy, and they always think that it is as a result of a problem, because they can compare themselves with their Caucasian counterparts, and they think that it has
yeah.
to be something to do with polycystic ovaries.
Yeah, exactly. And I explain it now. Sometimes they understand it very well, because I'm sure all of us have been through a phase where we thought we had excessive hair compared to anybody else. And then they calm down. They think, yes, my mother has it. You ask, was your mother hairy? Is your sister hairy? So then the conversation starts like that. Now the question comes back to, when does this polycystic ovary start? When does this start? Like I said, you have genetics, but you also need a right environment. And one of the biggest environmental factor is weight gain. Now, when the girls are before puberty, their hormones, follicular stimulating and luteinizing hormone, which are responsible for the female's secondary sexual characters and fertility, are very dormant. Nothing is happening. As they approach puberty, there starts to be a pulse. First FSH, that is follicle stimulating, then LH. Now, the pulses get bigger and bigger. In some girls, particularly those who are obese, this LH pulse is very, very high. So this LH works on the testosterone producing cells of ovaries, bearing in mind 50% of testosterone in female comes from ovaries and 50% comes from the adrenal gland, whereas in men 90% comes from the testes. So this 50% of testosterone, because of high LH, produces more testosterone. Now go back to the point where they started to put on weight. When you put on weight, you have to secrete more insulin to balance your blood sugars. So we define this weight gain and high insulin as a state of insulin resistance. So in layman's term, that means in a thin person, 10 units of insulin will keep your blood sugar between 5 and 6. Here you are looking at 26 units. Remember, we are born with a genetic and a limited capacity to produce insulin over lifetime. If you start producing insulin such high levels at earlier on, you have a very good chance of becoming diabetic when you go into your late 40s or 50s. So this insulin resistance, high LH, they both drive excessive androgen production. And when androgens happen, they do not allow the ovulation to happen or the follicles to mature. Multiple follicles will start growing, but not they don't go on to mature, and this we call as an anovulatory or without ovulation cycles. Or if the weight gain is so much, these girls can
So
stop
there is a
bleeding.
direct link between obesity and polycystic
Yes.
ovarian disease. So
Yeah.
one of the misconceptions is that some girls who have got high BMIs, they feel that they are obese because of the polycystic ovaries, rather than obesity is making it worse. Could you kindly explain
Yeah, I always say,
what leads to what?
yeah, I think it is the obesity first, because you need, for polycystic ovary syndrome or polycystic ovarian disease, you need androgens to produce symptoms. And androgens are as a result of directly insulin resistance. And again, one of the studies has very
And
clearly
just to
shown,
clarify, the androgen means male hormones.
male hormones or
Yeah,
testosterone, sorry,
yeah.
testosterone like hormones. So studies have very clearly shown that polycystic ovaries patients with high BMI are as insulin resistant as type 2 diabetic. So the levels even in lean and thin polycystic ovaries can be high, but they are not manifesting so much because they have kept their body weight in check. And now with the current use of so many medication available for obesity and also bariatric surgery obesity, you will see as soon as they have surgery, particularly if they have high BMI polycystic, just within a year they go on to conceive. That shows you that element of high BMI is extremely important in driving symptoms of this thing. And also, when there is an ovulatory kind of a cycle, they do get hyperplasia, endometrial hyperplasia of the uterus, don't have periods. And then I'm sure, Amara, you are much better, you know it much better than I know. Endometrial hyperplasia in the long term is also very alarming. So they do need to have periods at some stage.
Okay.
So
One more thing is that not having periods, you said that you tell girls that if they have 6 periods in a
yeah,
year, it should be fine, and they
yeah,
shouldn't worry too much about the
yeah,
fertility issues, because main concern is the fertility. But
yeah.
some women, they have 1 or 2 periods, and they feel that if they are not having periods, that is almost a sign that they can't conceive, even though it may not be true. So
Yeah.
how do you convince them? Because to have regular periods is a satisfaction and reassuring that they can
Yeah,
produce.
absolutely right. So then we are looking at the medical management of these patients, which I'll touch when I come to the management of these conditions. Because, like I said, 6 periods a year, I call it a milder form of polycystic ovaries. And with normal body weight, I wouldn't do anything much, accepting that if they're worried about, just put them on an oral contraceptive pill to give them breakthrough bleeding every month. But if there are less than 6 periods and say they have only 3 or 4 periods, I do introduce them a withdrawal bleeding. It's really important that their endometrial lining is shed off. So I'm sure you are well aware we use products like norethistron to induce bleeding and then start after every 3-4 months if they are not having bleeding, because it has some more implications later on. One very good sign of for looking when you are examining these patients whether they are insulin resistant or not is to look at underarms and neck. They get this velvety blackish pigmentation, which we call as an acanthosis nigricans. Is a very good marker of insulin resistance, and you don't need to even measure insulin to say they are insulin resistant. And I'm sure you have seen in your clinic, I have seen in my clinic, that these are the girls who will have problems with periods. They will be more hairy than rest of the polycystic ovarian population, and they are the ones who are going to require help. So when we talk about polycystic ovarian disease, we are looking at short-term complications, and then we are looking also at long-term complications. And when I talk about long-term complications, we go into the field of what we call as a metabolic medicine. So the short-term are they have gained weight, which has its own implications, subfertility, irregular periods. As a result of high testosterone and high insulin, they can have high cholesterol and abnormal lipids, which in the longer term will translate to higher chances of having a heart disease. Then definitely hirsutism, what is we call as the excessive hair growth, acne, which is another form of excessive androgen. The acne is mainly on the back, on the face, and this acne is very different from the normal acne. Is what we describe as a cystic acne and requires quite input from dermatologists. Now, at a very young age, if you do their fasting glucose, they will be high. And this we call as a impaired fasting glycemia. Now, impaired fasting glycemia, if you don't pay attention, about 60% of them will go on to become diabetic within 10 years. So it's really important. So something is telling you that you have to address these issues, particularly if patient is overweight. So the long-term complications translate as type 2 diabetes, high blood pressure, cardiovascular disease, depression because of this image issue. They, as they gain weight, sleep apnea, and also endometrial carcinoma because they haven't had period, endometrial hyperplasia. And when you do a health quality care questionnaires, they have a reduced health care related quality of life. So these girls actually require help. Now, the one problem I really struggle to deal with is hirsutism because there aren't many treatments which are available to treat hirsutism. And in spite of having dermatologists with me and the laser provision with us, we still struggle. The NHS, in extreme cases, after consultation with their surgery, will provide 8 laser electrolysis treatment, but that's not enough. They give 8 that will be mainly for the facial, but nothing for the body hair. After 8 treatments, they still require top up laser at least once a year for ongoing 5 to 6 years. So I agree, laser treatment is expensive when done privately. And
So
acne,
you're saying that NHS does offer treatment
yeah,
for girls or women who have got a very
yeah,
prominent facial hair.
facial hirsutism, yeah, but
Okay.
only for facial hirsutism, not no area. And if you go on the nice guidelines, there is a recommended set of criteria where you can refer these girls for laser or NHS. And but because of the funding issues, there can sometimes be problems. But yes, it is. So, how do we diagnose polycystic ovaries? Like I said, you have a history, you have examination, you have blood tests. You are mainly looking at male hormone like levels and male hormones, particularly testosterone. And nowadays, we are also looking what we call as a free testosterone in females. It is difficult to do, but is much more sensitive than doing a total testosterone value. And in presence of high testosterone, irregular periods, this is sufficient to diagnose polycystic ovaries. But then you can confirm it by doing ultrasound scan. And these are what we describe as Rotterdam criteria. Just last month, the criteria for diagnosis of polycystic ovaries were kind of updated. And in addition to these things, they have also recommended to check for other adrenal kind of male like hormones, which now are being offered as a part of a panel for checking polycystic ovaries. And also anti-Mullerian hormone, which is very high in these because the follicles are there, but they don't mature to go on to ovulation. As it has just
And this,
been
sorry
added.
to interrupt,
Yeah,
Dr. Bano, it's anti-Mullerian hormone. I understand that this is a test that NHS didn't offer because it is apparently a very expensive test.
yeah,
So in girls or women with significant
yeah,
impact of polycystic ovarian syndrome or
yeah,
disease, this test is available on NHS
yeah.
now?
Now it is available. It has been available because of this just guidelines update, right? But you can see they do say there is no point in offering these tests to adolescent or girls who are not going into it for reproduction. It becomes important when they're looking for family or fertility. That's
And
when
when it
you
comes
can
to reproduction, of course, one of the worry is that if they're not ovulating
yeah,
regularly and they don't have a regular cycle, they may need some help to get
yeah,
them
exactly.
pregnant.
Exactly. And that's where I said I'm the multidisciplinary team, and that is where the reproductive gynecologist is of great help to these
And
for
for
these
such
patients.
girls or women who are diagnosed with the polycystic ovaries,
Yeah,
you would recommend that if they have been trying to conceive and they have
yeah,
not been successful, currently the recommendation is that wait for a year or a year and a half.
yeah,
But
yeah.
in these girls and women, they should be referred for fertility investigations sooner rather than later so that
Sooner than
treatment
later,
can be started
exactly.
early.
Because they have been in the clinics for a long time, right? So when we look at the ultrasound scan, uh, particularly in young girls, there is one condition which is commonly mistaken for polycystic ovaries, and this is multifollicular ovary. Now, where does this happen? Multifollicular ovary happens just when the girls are going through puberty. And it does look like, but the cysts are more central rather than peripheral. And number two, in girls who are recovering from eating disorders. So this is completely different ballgame compared to polycystic ovaries. So these girls have had either a eating disorder, stopped periods for a long time, and now they are going through like second puberty or just soon after puberty when there are irregular periods. You get these small follicles which are more central than peripheral. So you need a very experienced ultrasonographists to tell you, is it a multifollicular ovary or is it a polycystic ovary?
Yeah, I agree,
When
because
we
I think the diagnosis sometimes, if they are overdiagnosed, especially in young
yeah,
girls, and the
yeah,
criteria of diagnosis in young girls, I think they are not supposed to, the sonographers are, the guidelines
not
are not
supposed.
to give the diagnosis unless there are other signs or symptoms.
Absolutely right. And that has to be done in conjunction with the biochemical testing, clinical findings. Now, the polycystic ovaries are generally tend to be bulky and large, and there are usually cysts in the periphery, like a necklace, beads of the necklace in the periphery, more than 10 in number. And like I said, there is no universal treatment for polycystic ovaries, and it has to be individualized based on what does a woman want, what is the severity of the symptoms. And the treatment modalities are: number one, conservative. If she's having 6 or more periods a year, hasn't got excess male hormone, is not overweight, leave her alone. That's fine. The second part is a medical treatment. Now, I think from medical treatment point of view, when endocrinologists come in, we are more looking at addressing the insulin resistance part of it. The other treatments, as you are aware, include contraceptive pill, which gives them excess of estrogen, and also gives them regular breakthrough bleeding. But the underlying process is still there. And particularly if you start this at a young age, you hope that that confusion between multifollicular ovary and polycystic ovary will be cleared by the time they come into the phase of having a more reproductive and other treatment. So the first medical management from my point of view is address the weight. Really, really important. Diet modification and weight loss. So here I'm going to talk a little bit about the diet, particularly with polycystic ovaries. It's well recognized that polycystic ovaries and high glycemic index carbohydrate, which are broken very quickly, do not go very well. So if you have to have carbohydrates, use complex carbohydrates. That means use brown pasta, brown rice, brown bread, which is broken down slowly. Avoid highly refined sugary food, because in order to digest that food, you require an increased surge of insulin to cover that, whereas the complex carbohydrates are broken down slowly and insulin comes in a slow and steady phase. So I tell my patients, if you want to have carbohydrates, have them in the breakfast or have them in lunch when you are active and running about. Avoid carbohydrates in later evening meals when you are not going to be physically active. And that's really important point, because we do not, insulin is high, we do not want them to have peaks of insulin. So that's one. The number two goal is to restore their regular periods. If they are having less than 6 periods, they are not getting breakthrough bleeding, and that means we are looking at using hormones to either a contraceptive pill, and or we are using people who cannot tolerate estrogens, using progesterone or norethistron to give them breakthrough bleeding at least every 3 to 4 months. Then the third aim is fertility, restoring that, and then also treating their hirsutism, acne, and prevent endometrial hyperplasia, and reduce the chances of endometrial carcinoma.
So, Dr. Bano, you mentioned about the use of contraceptive pill. So,
Yeah,
culturally, Asian families,
yeah,
especially parents, they used to consider their daughters
yeah,
being on contraceptive pill as a stigma, because, of course, you know
yeah.
why. So, do you think there is more acceptance and more understanding of the use of this treatment for young girls when they come to your clinic now than compared to previous
Yes,
years?
absolutely. About 10 years back, no mother would have said, no, they are not going on a pill, full stop. But now there is a lot more acceptance. I think girls, particularly now, are taking more responsibility. And still, my first choice is to make them have their own periods, and I will use non hormonal treatment. But if the periods are so irregular, then it's definitely worth trying, because it lowers their testosterone. It also increases the SHBG and increases estrogen, which can help. Now, like I said, I always struggle to treat hirsutism. Um, there is a topical treatment which is available. This was first produced by the company who makes the shaving cream Gillette. It's called
Okay.
efluorothiene hydrochloride. It's a Vanica cream. So what it does, it stops hair growth in the hair follicle because it blocks the enzyme. It has to be used topical. It's very expensive. GPs are very reluctant to prescribe, but it can be used on short-term basis till they can have permanent treatment. You have to apply it twice a day. It can be used as a foundation and has good effect. Then there are certain drugs like what we call as an anti-androgens. And out of anti-androgens, the one drug which I'm very fond of is cyprotrone. It directly blocks the combining of androgen to androgen receptor, so it can't work. But here, if the female is in a reproductive age group, you have to make sure they are also on a contraception because they should not conceive while they are on cyprotrone. Maybe for female child it will be all right, but for a male child it will have huge implications.
So,
The
Dr. Bano,
other
you
drug,
must be aware there was a pill which did have separatone in
yeah,
it, and
Dianet,
then it
yeah,
was kind of like disappeared from
restricted.
the market because of
Yeah,
increased risk of thrombosis. So,
yes,
is
exactly.
there an alternative to that pill?
Yes, there is no alternative available currently. So you can use cypertron separately, right? Um, as a separate, and then you can add a contraceptive pill. But you have, this is really important. That's why this drug went out of fashion, although it worked really, really well. So the other drug, which again you need contraception, the most potent male hormone for hair growth is not testosterone. It is a conversion of testosterone to what we call as a dihydrotestosterone, which works in the skin. And there is a drug which is available to block this conversion. And we use it for a lot of prostate carcinoma. This is the drug called finasteride. Extremely useful, very good effect on the hair growth. But again, you have to warn patients to be on contraception and not have even conceive, at least stop for 6 months before they are even planning to conceive. So these are few drugs which are available. And then there are like physical methods, like creams, like hair removal creams, threading, and other like laser treatment. And even before laser treatment, there used to be a electrolysis, quite painful, but very, very effective treatment. So, what about how can we make sure if you are going to use these drugs, like the one blocking conversion, like the one androgen receptor? One of the drugs which is again safer is spironolactone, but it is not licensed to be used in UK, and doses are very, very high. It can cause problems with liver, so you have to monitor. It's basically a diuretic which has an anti-androgen action, but some of the patients, being in a hospital setting, we can use it and it's quite effective. The other thing would be to use an intrauterine device, contraception device, and give them these drugs. Then you are at least making sure that there will be no mishaps.
And you
So
mean the hormonal contraceptive device?
yeah, yeah, hormonal contraceptive device that which works more locally, less chances of thromboembolism, and then you can use associated these finasteride or spironolactone or cyprotrone. So my interest in these patients is using insulin sensitizer, and one of the drugs which I'm sure you use it, I use it all the time, is metformin, the same drug which we use for type 2 diabetes. So metformin, NICE in 2004 approved this drug in secondary care only. So it reduces peripheral insulin sensitivity. By reducing the insulin resistance, lowers the level. It stops production of glucose from the liver and also enhances the uptake of glucose into the muscle. So when you look at, so it is working on two fronts, lowering insulin, getting blood sugars better. So as soon as, but it takes a little bit longer time. A lot of these women without even a contraception pill on metformin will regularize a period. And the
And would
other
you
drug
give this
which came,
to girls who are slimmer and not
yeah,
on the overweight side? Would you still give them?
if they are having irregular periods, I would always try them just to establish the periods. So this is a non-hormonal, like you said, the stigma associated with Asian girls, they can use it because they have seen somebody using it for diabetes in the family, nothing to do with contraception. The other drug which came into use was glitazones, but unfortunately they were taken away because of side effects. They were good drug for type 2 diabetes as well as polycystic ovaries. Now we are in an era of weight loss and diabetes drugs. And one of the class of drugs which works like a dream in these patients is what we call as a GLP-1 agonist. It is an injection once a week. It lowers insulin. It makes you lose weight. And unfortunately, these days, we cannot find anything in the market because all celebrities are taking it as injection to keep slim. But this really works extremely well.
And this is
And
available on NHS for these
this is, yeah, for
patients.
obesity. There are strict criteria like a BMI of 40 or above, amenorrhea, and associated pre-diabetes, not diabetes, like pre-diabetes or impaired fasting glycemia. You can use them. And I have used it and I've seen wonderful results on these patients. The last option where we are addressing the weight loss and everything is a bariatric surgery. Like I said, we have a cohort of about 30 patients struggling to conceive, BMIs of high 40s, early 50s. Soon after surgery, they lost about like 30 kilograms weight and they conceived and they have a baby boy. But I'll talk about these patients a little bit when we talk about bariatric surgery, the complications in pregnancy.
That would be
We,
great, Dr. Bano, because the thing is
yeah,
that what we are getting, and I'm sure viewers would have got this message, that the cheapest treatment is lose weight. It doesn't cost anything. It just regularizes everything without the need for any
yeah.
medication or any hormones.
Right. And then we are coming to treatment of infertility, where I think you are much more expert than I am. And this has to be done in conjunction with reproductive gynecologists. You can try drugs to induce ovulation like clomiphene, metformin, and you can use gonadotropins or even assisted reproductive technology. The problem I only find is because people are leaving it too late to conceive, and underlying polycystic ovaries makes them at a higher risk to miss that NHS open window. I don't know in your CCG what is the target, but we will not offer anybody above the age of 39. Is that right? Assisted reproduction. Hello?
CCGs are more relaxed about that.
Yeah, okay. So because I work on endocrine side, this is what I'm trying to say. They generally will not accept a patient for NHS funding if they are about 39. So then they have to look at the private. And regarding their acne, we always take help of dermatologists here. Now, one of the questions is, like I said, like metformin being the choice of drug, a lot of these women will conceive on metformin. So metformin is an extremely safe drug in pregnancy. We have a huge number of data behind it, its safety, no issues. A patient with a polycystic ovaries, as you are well aware, Amara, are at a very high risk of gestational diabetes if they haven't become diabetic. And then the complication, they tend to become diabetic even earlier than the age of gestational diabetes. So it is much safer to leave them on, because polycystic ovary not only causes gestational diabetes, but a higher chances of miscarriage. And that's what I would suggest is the treatment wise. Like you said, the easiest way to treatment is watch your diet, do exercise. Even 5% of weight loss can give you your periods back. And this we have seen in our clinics, everything. Now, there is another product which is not actually a drug and is not prescribable through NHS, myoinositol. Is one of the enzymes which is involved in insulin pathway. It's available in sachets and powder, and you can buy it in the pharmacy. It can be used with metformin, without metformin. It results in reduction of insulin resistance and restart periods. So this has another option available as long as you are ready to spend some money on. So,
So, I
see,
mean,
you have
that
tried.
it's thank
Yeah.
you so much, Dr. Gul Bano, for such an insightful and useful session, and you explained the disease very well. You discussed about the management and the treatment and whatever is available on NHS, etc. Would you kindly give one good message to our viewers who worry about having polycystic ovaries, just a message to reassure them and give them hope?
Yeah. See, number one, I would say, as long as you have your normal body weight, you have more than 6 periods a year, there is nothing to worry about. Just carry on as you are doing, but watch your diet, because with every year in age, you will gain some weight. So look after that. The second thing, if you come against a stumbling block, and now there are means which can help. The means are simply helping you to reduce weight, help you with the insulin resistance. Their tablets are at the most injection once a week. If that doesn't help, we are also looking at some kind of surgery to help you to lose weight. So my basic message is, please look after your weight. The rest of the things will fall in place. You are not only treating polycystic ovaries, but you are also preventing future complications of diabetes. Thank you.
Thank you very much, Dr. Gul Bano. Very interesting and very clear message, as well as the details. And I think what the main message is, avoid obesity, and we should have you on board to talk about obesity and how to help lose weight at another time. Thank you very much once
So
again for
thank
your
you
time.
very
So viewers, I hope you now have a better insight into what a polycystic ovarian disease or syndrome is all about, and where Dr. Bano gave a good insight into the management and treatment. One clear message she gave was, do not put on weight. Obesity makes polycystic ovarian disease worse, and it doesn't cost anything. So I hope it was useful. So goodbye for now. We'll be back with another episode next week.